Discussing today's topic, we have Carissa Little, our account manager, Jonathan Mthombeni, one of our business development managers, and myself, Kiabeth Santos, also a business development manager. So the team in front of you has a distinct pleasure of traveling the United States. We attend conferences and visit many hospitals to stay abreast on a national level with what is occurring with neonatal abstinence syndrome and other neonatal challenges. So with that, I hope you are ready with your hot beverage. And Carissa and Jonathan, are you ready?
Yes, Kia Beth, I am ready. I have my hot beverage here. Unfortunately, it is not coffee. I do love green tea. So cheers to you all.
Cheers.
I also am doing a tea today. I'm doing a rooibos, which is a red tea from South Africa. So I am ready to go. You know what, guys? We have a lot to cover today, and we want to make sure to respect your time. So, Carissa, why don't we just start with the foundations of the format for today, and just do some housekeeping.
Yes, before we get started, let me take a sip of my tea. All right, guys, I'm feeling refreshed and ready to go. So let's get started with the housekeeping rules. Please submit any questions that you may have to our email address at newborn@usdtl.com. I know that it's a lot of information that will be given, so we'll be sending out a recording of the session to all attendees to use for future use. And lastly, please do not forget the survey at the end, as we would love to hear your feedback in regards to our next coffee talks. All right, so now that we're done with the housekeeping rules, let's jump right into it with the topic of the day. So today's topic, we'll be talking about meconium and umbilical cord tissue testing. We'll be discussing newborn toxicology and how umbilical cord has enhanced newborn drug testing. So Kiabeth, to start us off, can you give everyone an overview of meconium and umbilical cord testing?
Absolutely. So to begin, I would like to discuss about the history of these specimens. So meconium, as we know, has been the traditional specimen of choice for many years. Back in 1991, USDTL was the first lab to develop the 5-drug panel. Shortly after, we had a nurse practitioner that said to us, no, there has to be a simpler way to collect a specimen for newborn drug testing. They felt meconium was too messy and it took long. So that's when the discussion of umbilical cord tissue evolved. So back in 2007, USDTL was the first lab to develop umbilical cord tissue drug testing. So now that we've discussed a brief history, we get a lot of questions in the field of what is the difference between meconium and umbilical cord tissue drug testing. So I would like to dive in a little deeper in regards to the main differentiators between the two. So to begin, I would like to discuss that over the years since we launched umbilical cord tissue drug testing in 2007, cord tissue testing has become the gold standard. Why is that, you may think? So let's begin with the first difference, is the ease of collection. So when we are looking at meconium tends to develop within 24 to 48 hours after the neonate was born. Whereas with umbilical cord tissue, it's available right in labor and delivery. So this helps the providers because they could get the results quite rapidly, because if you're able to collect the specimen quicker, you're able to send it off to the reference lab. We receive it right away and are able to flip around those results. So definitely ease of collection. Moving along to drug distribution. So this is something I love to hone in on. With umbilical cord tissue, based on scientific studies, it's been known that the drugs are evenly distributed throughout the entire cord segment. It doesn't matter which segment you collect, it's evenly distributed. Whereas with meconium, it differs because the drugs are not dispersed throughout each meconium passage evenly, for the exception of methamphetamine. So each time a neonate is releasing a passage, it has a different drug usage history. That is why we encourage the hospital staff to collect the entire meconium passage. Usually what I hear are stories that oftentimes staff collect nearly enough meconium of what a laboratory needs, but you won't get the maximum look back window with that because you need to collect the entire passage. So that goes back to why we're able to collect the specimen quicker too with cord and get your rapid results to the clinician. Moving along now to the third is a less chance for our missed opportunity. So this, my colleague Jonathan will be diving into a little deeper shortly. So as far as missed opportunity, what I mean is that with meconium, we often see a high percentage rate of quantity not sufficient, which means that we need to report the results as not being able to test. Oftentimes, if a neonate is born prematurely, they do not produce enough meconium. So we're not able to test the neonate for all of the drugs possible. And I've heard this story many of times, where the mom finds out that the neonate's meconium will be drug tested. What does she do? She goes, grabs a diaper, discards it, and there goes some missed meconium specimens and a missed opportunity, not only for a thorough look back window, but also to get the maximum amount needed so you won't get a rejection. With umbilical cord tissue, it's very rare to ever see a rejection with umbilical cord tissue because of the fact that it's available for every birth. It's clamped off right in labor and delivery. And then looking at the integrity of the specimen collection. So when we're looking at the integrity, what I mean by that is that with meconium, it involves multiple collections, multiple collectors involved. So there's a lot of room for error with this sort of collection for newborn drug testing. With us being a forensic toxicology lab, we really like umbilical cord tissue just because it improves the integrity of the identification of the baby, because there's only one specimen, one collector, one signature, and off it goes. So to sum it all up, I hear so many stories from our clients in the field. They tell me that they absolutely love the transition to umbilical cord tissue drug testing because they're seeing a big difference with the turnaround time just from the simple point of collection. Not only are they seeing an improvement in turnaround time, but with collection, they do not miss the meconium collection and that messiness. They always say, we do not miss collecting the meconium. They love the fact that they're able to collect the cord and send it right off. And then the providers love it because they have mentioned they can take early intervention for both mom and baby. And the social workers don't have to chase mom and baby down after the fact. These are once in a lifetime specimens. There is no room for error. Once it's gone, we can't go back and recollect. So definitely a lot of benefits with umbilical cord tissue drug testing. I advocate for both, right? But definitely umbilical cord, we're definitely seeing benefits there.
Wow, awesome, Kiabeth. Thank you so much. There are so many great reasons, why umbilical cord tissue is a great pre-analytical specimen type. But sometimes we get questions, usually from neonatologists, about the analytical power of this specimen type. How does it compare to meconium? We've used meconium for years. It's known to collect these substances at high concentrations. So when we compare it to umbilical cord tissue, how do they stack up? Can we trust those results? Kiabeth, I know that there's been an article that was published, on this topic. Can you kind of talk us through where some of these questions might be coming from, and how do we respond to that?
Definitely. So, back in September of 2017, an article was published called The Comparison of Umbilical Cord Tissue and Meconium for the Confirmation of In Utero Drug Exposure. So, what this peer reviewed article touched base on was that there were some instances where the results between meconium and umbilical cord tissue didn't agree. So our world-renowned forensic toxicology experts, they felt compelled to write a letter to the editor. And it was to respond to the equivalency between meconium and umbilical cord tissue segments. So when we responded, we were able to explain that we were able to detect positives, whereas other commercially available labs would report out specimens as negative. Here at USDTL, we're committed to using the best technology and science available so that our partners can feel rest assured with the results we produce and have confidence in us. So with that, in this peer-reviewed article, there was some data that, Jonathan, I would love for you to elaborate on if you could shed some light on the data of this peer-reviewed article.
Yeah, absolutely. So, after going through this, our lab sent a letter to the editor, to the publisher here, to kind of address some of the questions that had been brought up. And so you can see in our letter to the editor, we have a table here. And so I'm just going to ask for that table to be brought up. And what we have here on this table, you'll see on the left-hand side are the limits of detection. And what jumps out at you is the fact that our limits of detection, in some cases, are just orders of magnitude lower than those from the commercially available tests reviewed in this study. And that leads to lower cutoff levels as well. So we can see here that our cutoff levels, in a lot of cases, our cutoff levels are even lower than their limits of detection. And that makes all the difference. So that translates into there will be some situations where these commercially available tests will report out a negative where we were able to detect a positive because our equipment allowed us to do so in our process. So by doing that, we have been able to show a great agreement between umbilical cord tissue and meconium. And so we're very positive about that.
Yeah, this elaborates on the importance, Jonathan, of cutoff levels. So, for our audience today, definitely you want to keep an eye on those cutoff levels because they do make a difference with your results. So, we usually get a lot of questions between how to collect these specimens. Some hospitals look at collecting umbilical cord tissue segments on every baby, some don't. There's a difference between targeted and universal collection. What are the benefits? So, Jonathan, can you elaborate on that?
Yeah, so let's just talk about definitions first. Targeted collection is where the hospital has a set of criteria that they follow to determine whether a specimen is going to be collected or not. So if mom meets that criteria or baby meets that criteria, then that birth will be flagged for that specimen to be collected and sent in. And that criteria can be, if mom missed her prenatal care, or, if she's just showing up at the hospital for the first time to have the birth, or if she had some complications during her pregnancy. All these things can lead up to a targeted collection. Now, universal collection is where the hospital decides that, for each birth we have at the hospital, we're going to collect that umbilical cord tissue and we're going to save it for 2 to 3 weeks. And if during that time, baby starts showing signs of withdrawal, or we come up on some other information that tells us that we should be testing this baby, we will have that specimen ready for testing. And Kiabeth touched on this a while ago, the fact that these are once in a lifetime specimens. And so what this does is it helps to prevent these babies from falling through the cracks. It helps to prevent those situations where baby starts withdrawing because the onset of withdrawal is variable, uh, and there's no specimen to be collected at that point to be sent in. Those are very difficult situations to deal with, and universal collection helps hospitals avoid being in that situation. So we really recommend that a lot. Carissa, I know that, we've talked about a lot already in terms of, you know, the comparison between umbilical cord and meconium, but what does it take to actually collect this umbilical cord? Now, you've worked with hospitals all over the country. You've trained a lot of staffs on how to collect umbilical cord tissue. Can you just give us some insight on what that process is like?
Yes, so my training with hospital staff has been very successful. I've done virtual in-services and actual on-site visits prior to the whole COVID-19 pandemic. And the hospital staff had said that the umbilical cord collection is fairly easy as it only takes 5 steps. So the first step is to cut a 6-inch segment of the umbilical cord. The second step is to drain the excess blood. The third step is to rinse the exterior or the outside of the specimen with normal saline. And then the fourth step is to pat that specimen dry. And then the fifth and final step is to take that actual umbilical cord specimen and put it inside the specimen collection container. And that's it. Your specimen is ready to be sent to our lab for testing. I mean, it's literally that simple. You know, in regards to specimen collection, Jonathan, I know you had some interesting data on meconium collection and how quantity not sufficient can affect the testing for the neonates. Can you go over that with everyone today?
Yeah, absolutely. So what we did is we asked the lab to send us 6 months of rejection data so we can kind of illustrate this point for you. And so if we look at this chart we have up here, we can see that meconium rejects out at a rate that's about 4 times the rate of umbilical cord tissue rejections. And that's huge. And I want to illustrate to you why this is the case. So just looking at this pie graph we have here, this first one is for meconium, and we can see here that the largest driver of rejections in meconium is quantity not sufficient. Quantity not sufficient is responsible for over half of all meconium rejections. And if we look now at the pie graph for umbilical cord tissue, we can see that by switching to umbilical cord tissue, you nearly eliminate the quantity not sufficient rejection because there's always sufficient quantity of umbilical cord tissue when a baby is born. And just by doing that, you can reduce your rejection rate by almost 4 times. That's been huge. Well, guys, we covered a lot today. Um, Kiabeth, you gave us such a great summary of the pre-analytical benefits. You know, we learned how umbilical cord is just easier to collect, how it's 100% available, faster time to results. We learned how this is a viable specimen type, and also how it's easier to maintain the integrity of this specimen when using umbilical cord tissue testing. I've really had a great time speaking with you guys today.
Absolutely. So, Jonathan, you gave us a great summarization of what we learned today. I hope our audience gained a lot of insight as that was our ultimate goal. Again, if you have any questions, as Carissa mentioned earlier, please ensure that you email newborn@usdtl.com. We will be doing our next coffee talks sometime in the fourth quarter of this year. So please keep on the lookout for it. And we look forward to you joining us.
Indeed. Take care, guys.
All right, bye, guys.
Bye.
Subscribe to our channel to see more videos like this.